morning, everybody. It's my great honor and happy to have you all here for the AEG local workshop on the EUS-Guided intervention at General Hospital. This workshop was organized by AEG and PTBD in the collaboration with the General Hospital. And this program also had support from all of us. And today workshop includes 2 sessions. In the morning, we will have 3 lectures done by AEG faculty. And in the afternoon, we will have the 10 live case with hands-on training in General Hospital. And now I would like to introduce 2 speakers, Dr. Anthony Leon from Singapore and Dr. Yu Ting Kuo from Taiwan. And today it's our great honor to have Dr. An and Dr. Kuo here for this morning session. Thank you very much for taking time to join today's webinar. Thank you very much.
Thank you. Thank you.
So now, before the lecture, we will start the pre-test. And we will have the 5 questions. On the participant need to answer these questions in 5 minutes. And Jason, please launch the pre-test, please.
Good morning, everyone. I'm going to launch the test. So today for the pre-test, we'll have 5 questions. So I will last for 5 minutes. So please take your time to answer the questions. So the question for post-test is the same as the pre-test. So after the lectures, we'll have another test, which is post-test. So and after the post-test, the answer of the test will be explained by our faculties. So now I'm going to launch the test. For the attendees, which is online, you will see in Zoom, you will see the test pop up in your screen right now. For those who are in hospital right now, so our local staff from Olympus will help to distribute the question to you. So, and from my screen, I will show the question, each question for 30 seconds, for 1 minute. So altogether 5 questions. So now please take your time to answer the questions. So now I'm going to show the question too. question 3 now. Now question 4. Now, last question, question 5. Okay, it's about 5 minutes, so that's the end of the pre-test. Thank you for your participation.
Okay, Jason, thank you very much. And now I would like to welcome and introduce Dr. An for the first lecture about the EUSFNA and FNB. Before the lecture, let me do a quick introduction about Dr. An. Dr. An Leon now working at General Hospital in Singapore, where he is the chief and senior consultant of gastroenterology and hepatology department. He also is the director of endoscopy center. He is the adjunct associate professor at John Lully School of Medicine, National University of Singapore. His research interests include acid-related disorder, biliary infection, pancreatobiliary disease, image enhanced endoscopy, therapeutic, ERCP, and EUS. Dr. An, please start your lecture.
Hi, good morning. Can you hear me and can you see the slides well?
Yeah, very clear.
Okay, good. So today I'm going to talk firstly about EUSFNA and FNB. FNA actually forms the basis of us performing therapeutic EUS because it is the foundation skills that we all should learn. And therefore, it is very important. Of course, most cases we see for tissue acquisition for FNA, and therefore it's important that we master this skill very well. We all know that FNA is actually very important, and as long as we can reach the site of interest, we can perform the biopsy. I want to go through these few points about how we can make the technique better. I think first of all, before we start, we have to look at the indication, whether or not we really need the tissue confirmation. Sometimes we need FNA, sometimes we need FNB. So having an idea before we start is important. Also, we must be sure that there's no contraindication for purpose of patient safety. Yeah. So tips. First, I think when we see the lesion, we must put it in the best optimum position so that the direction of the needle is optimal, and we should avoid areas of necrosis. Areas of tumor necrosis would not give us much information. There may not be any tumor cells. We should avoid areas of calcification. We should not puncture a cyst unless we are prepared to do a cyst puncture for fluid analysis. We should always do a Doppler before we start to avoid blood vessels, and we must avoid the main pancreatic duct in order to avoid pancreatitis. Second is if there are major blood vessels beyond the site of puncture, maybe it may be safer to measure how far the needle must go in and lock the needle so that we do not accidentally puncture the blood vessel. Second point is if the lesion is very hard, it may be safer, maybe easier to use a 25 gauge needle, which is more sharp. For a hard or moving object, sometimes it's important that we do a quick puncture so that the thing can get, the needle can enter the lesion easily. And last but not least, when you do a puncture, we should sample different parts of the tissue called fanning in order to maximize our yield. Suction, normally I will use suction unless in order to improve the diagnostic yield, because a lot of time we send tissue for histology. So just to show that, you know, so if we are going to puncture something hard, we should actually lock the area so that we do not accidentally puncture beyond our intended depth of insertion. So this is just to show how we hook up the needle and how we can actually, in a very controlled manner, advance the needle and control the puncture. If we are very sure that there's no, of course, we can also do it freehand and not control the depth of puncture, then we have to use our hands to control, all right? So just two examples. This is a patient with a lymph node in the mediastinum. This is a subcarinal area. So you can notice that when we puncture, we should actually sample different parts of the tissue. We can do it by moving the elevator or by moving the scope. So, and you can notice that even though the blood vessel is very near, the aorta is nearby, it can be very safe because we do it in a controlled manner. In this other example, this is a left adrenal gland nodule. So again, we can see the lesion. We target at in the middle where is the maximum, is the best location. And after we have punctured, we do fanning in order to sample different parts of the lesion. So once you acquire the tissue, normally what we do is we use a stylet to gently push out the specimen because we do not want to use a syringe and cause the material to spray out. And we will smear the fluid on the slides for cytology and place in formalin for histology assessment. In order to ensure that we have enough tissue to make a good diagnosis, we have actually 4 options. One is getting a technician or a pathologist to help us assess the adequacy of cytology by looking at the microscope at the same time. Or we can actually ourselves look at the amount of tissue that we obtain. We call it microscopic on-site evaluation of MOS. If we're not very sure of these two, we can also, based on literature, puncture a minimum number of times in order to ensure that we get the maximum yield. So normally for lymph nodes, we should puncture maybe 2 times. For pancreas, maybe 3 to 5 times. But if we use a biopsy needle, we can actually decrease the number of puncture. So normally if I use a biopsy needle, I have no rows. So usually I puncture maybe twice, even for pancreas. In terms of choice of needles, I mentioned this earlier. So 25 gauge needle is the sharpest. So it's the easiest to use, especially when there's angulation. 19 gauge can potentially give us core tissue, but it's more stiff. So we must decide also whether we use FNA needle or use a biopsy needle. I think right now in the market, there are different brands of biopsy needles from different companies. And they are very easy to use, just like a normal FNA needles. Not like many years ago when you had a true cut needle, which was very challenging to use. So you can appreciate from this picture, this is what we have from cytology, this is from histology. So we can get more material from his FNB. And again, we need FNB to help us diagnose a lymphoma, for instance. This is an enlarged lymph nodes. FNB help us diagnose lymphoma. And this is a submucosal tumor of the stomach. Usually we suspect GIST, but sometimes SMT in the stomach can also be leiomyoma. This meta-analysis was published recently. It shows us that if we use the FNB needle, we can increase diagnostic accuracy, we can get more core tissue, and we need to puncture less times. And by puncturing less times, maybe we can make the procedure faster, and maybe can increase our patient safety. In terms of what biopsy needles to use, normally we should use one that is forward cutting, either the forward whole core or short core acquired, because this can give us better tissue. And if we want to do genomic profiling, I think certainly we must use a FNB needle because it can give us more histology tissue. Even though normally FNB is, the needles are a bit more expensive, I think it can be cost effective because we can increase the success rate, and also we do not need rows. Nonetheless, I think a FNA needle is still relevant in the following context when we do not have FNB needles. In situations where there is a high risk of bleeding in theory, when there's a very sharp angle in the puncture tract, so we need a smaller needle, such as in the second and third part of the duodenum. When we think that cytology alone is enough, when you're using it for cyst fluid aspiration, or when you're using an FNA needle actually for EUS-guided therapy. In this case, normally we need a 19 gauge FNA needle to help us do these EUS-guided interventions. Last but not least, I think we should remember the complications of EUS and FNA. Normally, it is very safe, similar to OGD and colonoscopy. Just beware that when we puncture cyst fluid, we should give antibiotics prophylaxis to decrease the chance of infection. And secondly, when we puncture pancreas, avoid the main pancreatic duct. Otherwise, there's a risk of pancreatitis. Thank you very much.
Okay, thank you very much, Dr. An, for a very nice lecture. Any question?
Dr. An,
Yes.
if maybe clinical practice now, what frequency of your FNB use?
Oh, what frequency?
I mean which you prefer now, FNA or FNB, if you got like a pancreatic and solid tumor?
For myself personally, for solid masses, routinely I use a FNB needle in all cases, and usually I puncture 2 times only. We are involved in some multi-center randomized controlled trial. So when the patient is for the trial, then we could be using another needle as part of the study. But for non-study, I use FNB needle for all solid masses. Unless, like I mentioned, there are specific precautions, such as when the patient has a higher risk of bleeding, or when it's a very sharp angle like D2, D3, where it is very difficult to insert a larger FNB needle. Then in those cases, I may use a smaller FNA needle. But the routine cases, I use an FNB needle.
Do you have any kind of FNB that you are particularly prefer?
I think I have to be neutral. And if you look at the data, I think the results of FNB needles are comparable between the different companies. I've tried out all the, except for the FNB needle by the Chinese company Microtech. I've tried the Sharp Core, Pro Core, and also the Acquire needles. For us in the hospital, sometimes we do bulk purchase. So the needle we use also depends on the hospital tender by the different company. But I think if you look at the literature, it will suggest that the needles are comparable. But the only caveat will be that a forward cutting needle might be better than a reverse edge cutting needle. So maybe a 20 gauge Pro Core might be better than which has a forward cutting might be better than a reverse cutting Pro Core. Yeah. Yeah.
How many times puncture enough?
Okay, the question is how many passes I puncture for FNB needle?
Yes, right.
Normally when I puncture, after I puncture, I also look at the material that is that I obtain, and I should be able to see a tissue core with an FNB needle. Most of the time, 1 or 2 passes is enough. I'll usually do 2 passes, even if I see material in I must say, many times I can see the tissue core in 1 pass already, but usually I'll do 2 passes. If after 2 passes, I still do not see any material, then I may increase my number of puncture, but my average number of puncture with an FNB needle is 2.
So, rows available in Singapore or not?
Sorry, rows?
Yes.
I think in some hospitals in Singapore, they have rows. In my hospital, we do not have rows. And personally, I do not quite like rows because I think it takes up time. After we puncture, we have to wait for the pathologist to dry the slide, look under a microscope and so on. And yeah, so maybe it's good for trainee because they have more time to practice on the patient when the pathologists look at the slides. But normally I prefer FNB without rows because I can get the tissue and also it makes my procedure faster.
Okay, thank you very much, Dr. An. And next topic, the EUSBD and EUSGBD will covered by Dr. An. Okay, so Dr. An, please.
Okay, let me share screen. Can see, right? Okay, you can see my slides on EUSBD and GB.
Yes.
Okay, good. So, all right. So my agenda is to talk about EUSBD and EUSGBD. Before we start, I'd like to provide overview. First, we'll talk about EUSBD. I think before we start, because sometimes we get too carried away with the technical details, so we must remember the role of EUSBD in the overall scheme of things. I think normally we might employ EUSBD in the case of malignant biliary obstruction that is not a surgical candidate, and where ERCP is not successful, because I think ERCP is still the should still be the first line approach. Second, I think just to remember, EUSBD and EUSGBD are actually adapted from the technique of EUS-guided pseudocyst drainage. So this is a usual pseudocyst drainage here. And therefore, instead of puncturing the pseudocyst, you just puncture either the gallbladder or puncture the bile duct for drainage. So essentially, we're adapting the technique for EUS pseudocyst drainage to the bile duct and the gallbladder. Although we are using the same technique, we have to remember there are some important differences that can affect patient safety, and we must be very mindful. First, the gallbladder and bile duct, they are not adherent to the duodenal wall. So therefore, there is a risk of wall separation. There's a risk of free perforation. So this is important because sometimes when we puncture, we can actually pull the wall apart. Second, there is a space constraint. Normally a pseudocyst is very big, so we puncture, there's a lot of space for the needle to go down. But in the case of the bile duct and gallbladder, the space for which the needle to puncture through sometimes is a bit smaller, so we must be careful. There are also important blood vessels around the bile duct and gallbladder, which we must take care, such as the gastroduodenal artery and the portal vein. Sometimes if we don't take care, we can actually potentially puncture through the whole bile duct and enter the portal vein in the case of CBD drainage. Number 4, the scope position a lot of time may be a bit unstable, so we have to hold it in such a way that we try to minimize the instability. Because the bile duct and gallbladder are not adherent, if we fail, there's a high risk of severe complications such as bowel leak, free perforation. And normally in the case of drainage, we prefer a covered metal stent to plastic stent in the case of bile duct and gallbladder drainage. So what are the approach we can do for EUSBD? This was a paper published by the AEG group 2 years ago in GUARD. We can use it for simple access and then use it to do EUS-guided rendezvous ERCP. We can do EUS-guided drainage such as an antegrade stenting, or we can do a transmural drainage such as either a EUS choledochal duodenostomy or EUS-guided hepatogastrostomy. I will show you some videos to illustrate all these examples. Some are my own cases, some are videos courtesy of my friends. So this video shows us a case of obstructed malignant obstruction of the bile duct. ERCP was not possible, and therefore EUS-guided rendezvous was attempted. So I want you to take note that in such a case, when you puncture the bile duct to do rendezvous, we are actually aiming downwards because we want the wire to pass downward. And so the position in such a way that the wire will go downwards towards the major papilla. So after puncture, the puncture is confirmed by control injection, and then guide wire goes down this way. And once it goes down, then we do guide wire exchange by withdrawing the EUS scope and then inserting a duodenal scope. And then we can actually catch the wire, pull into accessory channel, and then cannulate the bile duct, just like the regular rendezvous technique. And then we can do stenting and all that. This is an example of EUS-guided antegrade stenting. The intrahepatic duct was punctured because this patient is surgically altered anatomy and the major papilla could not be accessed. So the intrahepatic duct is punctured and contrast injected to confirm the position. And then the guide wire is inserted. You can see it going down into the duodenum. The puncture tract is dilated. You have to realize that, I just want to show that sometimes when we do EUS-guided intervention, there can be some technical challenges. Like you can see this loop here forming. So we actually need to straighten the loop in order to maximize make the axis of puncture, make the axis of insertion more optimal. So you can see an initial loop, then this loop is straightened. Now you can see it's straightened, so that we can actually dilate the puncture tract. So this was a cystotom to dilate the puncture tract. And then after we have done that, then we can insert the stent through. So you can appreciate that position is probably not very stable. And what we need to remind ourselves is we must make sure that the axis is a line, it's a straight line, so that when you push it down, it can actually go down easily. Stent deployment is just like a regular SEMS deployment. So if we were to do EUSBD, transmural drainage, there are two approaches. One is a HES, puncture through the liver, like you saw earlier, but that was antegrade stenting. Or we can just puncture the bile duct. So if we do a transmural stenting, the axis of puncture is upwards, different from the rendezvous technique where it's downwards. So what are the equipment we can use? So we use a 19 gauge needle, a 0.25 or 3.5 guide wire. We have to dilate the puncture tract with either a 6-strand Suhindra dilator or 6-strand cystotome. This is because the FNA needle, the tract is very fine, so we cannot insert a stent after puncture, so we need to dilate the tract. And after that, we can actually either insert a fully covered biliary stent or a lumen apposite metal stent. Long time ago, when people first started doing this procedure, they inserted plastic stents as well, but plastic stents are not so good because they may migrate, there may be leak as well. I want to highlight one point. I mentioned this thing about dilating the puncture tract so that the metal stent can go in. What is important is that we do not over dilate. With a 6-strand dilation, it should be enough for the catheter to go through. When we expand the stent will just expand by itself. And because there is no excessive dilation, it becomes more, it fits the opening more tightly and therefore prevents leakage. So if you were to dilate too much, there's a risk of bowel leak, there's a risk of stent migration. So we should just dilate enough for us to put in the metal stent catheter and let the metal stent expand by itself so that it becomes a very tight, snug fit. So this was a patient I did some years ago. Patient had pancreatic cancer. I had actually put in a duodenal stent already. And so I had to do EUS-guided biliary drainage. This is a standard way we puncture and then we dilate with a 6-strand dilator. And after that, we insert the metal stent and allows drainage. So it's actually quite, it looks quite easy, but we have to remember each time we do this that because the scope is not very stable, you must have good coordination with your assistant or your nurse so that we do not lose the guide wire. When we want to do EUSCDS, the standard way is to use fully covered biliary stems. But the problem with fully covered biliary stems is that it's not lumen opposing. So sometimes there's a risk of separation, there's a risk of migration. So conceptually, it's very attractive to use a lumen opposing metal stent. This was another case that I did. Again, pancreatic cancer, ERCP not successful. So I this time around, I use a hot Axios to insert the stent. I actually use a 19 gauge needle to insert the guide wire first in order to protect the access. And once the guide wire has been inserted, then I use the hot Axios to directly puncture the bile duct. So you can see the device entering through. But I want you to note that just now I mentioned that the bile duct wall and duodenal wall are not adherent, so they can be separated. So in this case, after I punctured through, when I push in the catheter a bit, you can see the bile duct wall and duodenal wall separating. So this can be potentially dangerous, can potentially result in bile leak. But because this was a lumen opposing stent, after the stent was opened up, we could bring the bile duct wall and the duodenal wall together again, and therefore prevent bile leak. I also want to highlight that we must make sure there's enough space. If it's too small, if the diameter is too small, less than 1 centimeter, ideally best is if it's more than 1.5 centimeter, because when we use the hot Axios and puncture, sometimes it can go too far and puncture through the other wall and injure the portal vein. So ideally, minimum it should be 1 centimeter. Best if it's more than 1.5 centimeter before we use it. If the diameter is not big enough, maybe it's actually safer to use a fully covered biliary stems. So once you open the inner flange, we can bring everything together. And then and we achieve our drainage successfully. This is example of HGS. When we want to do a HGS, we use ideally we use the stems, and it has to be long enough. So if we do not have stems that's long enough, then maybe it may not be so ideal to attempt HGS. So we look at the dilated intrahepatic duct, avoid the blood vessel, puncture it. So you can see all these concepts are similar. We see the thing, puncture it, and then insert, confirm it's inside by injecting contrast. Then we insert a guide wire, and we dilate the puncture tract, and then we insert the metal stent. So this is good if you are draining the left side of the liver, because we can actually easily access it from the stomach. This is a meta-analysis published 3 years ago. It compared EUSBD with PTBD. And you can see that both approaches have similar success rate, but EUSBD has a higher technical success rate. And this is because they use, when you do internal drainage, you're using metal stent. And because the diameter of drainage is bigger, so it can provide more effective drainage, and there's no risk of tube dislodgement. Now I move on to EUS gallbladder drainage. In the case of acute cholecystitis, I think the standard of care is laparoscopic cholecystectomy. For a patient who is a non-surgical candidate, either we give antibiotics alone with no further intervention, or we can attempt either transpapillary gallbladder drainage through ERCP, percutaneous gallbladder drainage, or EUS-guided gallbladder drainage. This is an example of EUS-guided gallbladder drainage using a multi-step approach like what we saw earlier for the bile duct drainage. In this case, the Spexus was used. So you can see this is a distended gallbladder. The gallbladder wall is a bit thickened, consistent with acute cholecystitis. Is punctured. Guide wire is inserted. It coils inside the gallbladder. The puncture tract is dilated by a 6-strand schistosome, just similar to the EUSBD. And then a small balloon, again, not too much, in this case just to 4 mm, and then after that the stent is inserted and deployed. When we do this procedure, we must be mindful of potential pitfall. And this pitfall applies to both the EUSBD and EUSGBD. After we have puncture, we must make sure that we keep the guide wire in the correct axis. If it becomes, if we lose the axis, we can actually have stand malposition or even free perforation. So we must keep our scope position constant and make sure that the puncture is the direction of insertion of dilation and stent insertion is the same as the initial guide wire insertion. And this also means that we should not have any endoscopic view. We should just maintain the EUS view and fluoroscopic view. This is a one-step approach using the hot Axios. So in this case, this is the gallbladder. We just puncture directly using the hot Axios system, open up the hot Axios, and then deploy it. So we do away with the FNA needle. We do not need the guide wire. We do not need to dilate the tract. This meta-analysis was published recently. It's still in press in GIE. It actually compares EUS-guided gallbladder drainage with percutaneous drainage and transpapillary gallbladder drainage. I think in terms of technical success rate, they're all similar. But when it comes to the clinical success, I think the EUS-guided gallbladder drainage is similar to the percutaneous drainage, but better than the transpapillary approach. In terms of safety-wise, I think the EUSGBD can be very safe. And when we do EUSGBD, there's actually a less need for intervention compared to a percutaneous approach. Thank you very much.
So thank you very much, Dr. Han. Is there any question? So, Dr. Han, in the EUS guide rendezvous, which position is better? I mean that the root puncture.
I think to puncture, we should try to aim a distal bile duct.
EUSGBD or EUSCD, you prefer to do the EUS-Guided recommended technique?
Oh, I see. So I think both through the liver and through the CDS is, I think both are okay if you are inserting guide wire for access. Yeah. Sometimes it might be easier to do the access to the distal bile duct because there's less track for the guide wire to move through. Yeah. But most of the time, for me personally, I only do I tend to do EUS-guided drainage only for malignant obstruction that is not suitable for surgery. So in these cases, I find the rendezvous maybe a bit more troublesome. So I would actually do a transmural drainage with a stent, and that makes the procedure much simpler.
Dr. An,
Yeah.
if you can successfully puncture the bile duct transgastrically, and you can run the guide wire into the duodenal. So how do you choose between antegrade stenting and HGS? How do you choose between the two possibilities that you can do?
I see. I think personally I would if the guide wire can actually go through the obstruction such that rendezvous is possible, then and if the papilla, okay, so normally we'll do antegrade stenting if we cannot access the papilla.
Okay.
Some patients have a surgically altered anatomy or there's a duodenal obstruction so that the papilla cannot be seen. In such a case, I think then we should just go ahead and do antegrade stenting. But if we are able to see the major papilla, then and we can do a rendezvous, then the rendezvous might be better because we can see, we can control how much of a stent sticks out of the papilla. Because sometimes I think when you do the antegrade stenting, to control how much stent actually stick out might be a bit more challenging, and we also need to dilate the puncture tract, make the stent go through a lot of a long journey. Yeah.
Do you have any case that after antegrade stenting, but you still have a bile leakage through the needle tract, transgastric tract?
So I think that is always the theoretical concern because you have to you have to dilate to insert the SAMs for antegrade stenting. I think that is precisely the point where, for me, if I can access the papilla, I would do a rendezvous instead of antegrade stenting because two things: one, minimize the risk of potential bile leak. Second, I can control how much of the stent actually sticks out. But I want to add, like what I mentioned earlier in my first point, if the patient has unresectable cancer, I think sometimes we want to do the simplest technique to drain the obstruction. And to me, if that's the case, I would either just do a HGS or I would do a CDS with STEMs.
In case of malignant obstruction, you do a stenting under EUS, or you will try to EUS guide the rendezvous technique first?
Sorry?
You do the rendezvous technique first, or you can, after puncture to the PD, you will try to do a stenting.
No, actually for me, right now, this is my current approach. If the cancer is not resectable, if it's of palliative drainage, if ERCP is not successful, I just do a transmural stenting. I do not try rendezvous anymore. because I think just a transmural stenting is very fast, it saves time, and we don't run the risk of losing the guide wire, because sometimes when you do rendezvous, the guide wire can slip out, and then we may run into trouble. So for me, for palliation of cancer, my approach now is if ERCP is not successful, I'll just do transmural stenting with SAMS.
So you change to the EUS-Guided right after the first session, the film ERCP, or you wait for the second film of ERCP?
Oh,
Some author, they prefer to do the second. They choose the second trial of ERCP before proceeding to the EUS-Guided. What's your plan?
Oh, okay. So normally for us, if our ERCP is not successful, we do not try ERCP again, because I think, yeah. Second, I do not usually do on the same day of the procedure if my ERCP is not successful. So I'll stop. Then I'll do the next day after I discuss with patient. All my procedures are done under regular sedation with midazolam and fentanyl. So which means to say all my procedures must be quite fast. So if let's say my ERCP is not successful, then I'll probably just stop, and then I'll discuss with patient about EUSBD or PTBD, and then if they are agreeable, then I'll do the EUSBD the next day.
Right now. You feel second.
Okay. So for drug dilation, which one you prefer to use, cytotome or dilator, mechanical dilator?
To dilate puncture tract, I think both cystotome and 6-French dilator are equivalent. But I think 6-French cystotome is easier to use.
But it's related to the high risk for leakage.
No, because when you use after we've inserted the metal stent, the metal stent actually expands to 10 millimeter. So even if you dilate with a 6-French cystotome, there should not be a leak, because it should be very tight fitting.
Any question? So we don't have any experience in EUSGBD. So in your opinion, what is the most stable indication for EUSGBD?
So I think EUSGBD would be a good choice for patients who are non-surgical candidate and who do not want a PTBD, because I think right now the current standard of care is surgery, and sometimes patients may not want to go for surgery. In such a case, EUSGBD might be a good option, but you have to remember that in some cases, the acute cholecystitis can be very severe. Sometimes there could be emphysematous acute cholecystitis, where there's a high risk of gallbladder wall perforation. So in such cases, we should not try. But when it's not so severe and the patient doesn't want surgery, not responding so well to antibiotics, then I think EUSGBD can be performed. I think we also need to choose our patient correctly, because the gallbladder must be well distended. If the gallbladder is contracted, not well distended, we will not have much room to maneuver, and it will not be very safe. So I think just choose a patient with a well distended gallbladder, and we are very sure that the there's no risk of gallbladder wall spontaneous necrosis and perforation.
Thank you. I have a question about the assessment. When you do the transgastric scan, sometimes by how this go to the vascular to the biliary. What do you do with that?
Sorry, I can't hear very well. Yeah.
Okay, the question is how to manage the stent migration in case you do the EUSFNB.
Okay, so if it happens during the actual procedure, when we are the guide wire is still there, then we might be able to insert another stent across the stent. I think, but if the migration happens a few days later, then I think the patient will need surgery.
Okay, thank you very much for a very nice lecture. Thank you.
Thank you very much. Thank you.
Thank you. Okay, the next I would like to introduce Dr. Kyo for the final lecture. Dr. Yutin Kyo is now working at the endoscopy division at National Taiwan University Hospital. He attended many AEG EUS programs, including AEG the trainer course, Hong Kong 2015, international workshop on EUS guide, of very patriotic blue collection, Asian EUSFNB, and international EUS South Korea. And he also completed the training program of WEO International School of EUS 2018. Dr. Kyo, he also the instructor of EUS education program for HST Endoscopy Society of Taiwan in 2016. His main interest are all kinds of therapeutic endoscopy, especially EUSCD and interventional EUS in hepatobiliary area. And today, Dr. Kyo come with us the lecture on EUS guide anti-tumor therapy. Dr. Kyo, please.
Thank you, Professor Jun, your kindly introduction. Can you hear me and see my slide?
Yes, very clear.
Okay. Good morning, everyone. It's my great honor to join this FNA AEG local workshop on EUS-Guided intervention. Today's my talk is about the EUS-Guided anti-tumor therapy. Okay. As you know, just like Professor Antinon just mentioned lectures, EUS not only play a central role in the diagnosis, and it's like you can see this slide, EUS also can offer a platform to a wide range of direct tumor therapies. Just like you can see that this video. Oh, sorry. Sorry, I cannot play the video very smooth. Hold on. Okay. Okay. Because advantage of a EUS-Guided anti-tumor therapy because it's real-time image, and they can abilities to see the tumor while you perform the procedures. For example, in pancreatic cancer, in solid pancreatic tumor like the adenocarcinoma, or usually with the tissue desmoplastic response. And EUS-Guided anti-tumor therapy can broadly classified based on mechanism of action, like the direct method or indirect method. And during my talk, I will focus on direct method, especially more worldwide used, just like external injection and the radio frequency ablation. Okay, so my first part, I will talk about the EUS-Guided external injection. Just like the EUS-Guided external injection, because it is still being investigated, and up to now, according to current evidence, they only used for a select group of patients. And currently, I will summary current evidence, the ideal candidate for external injection. I will separate two parts. The first part is a pancreatic solid neoplasm, and the second is a pancreatic cystic neoplasm. Okay. So now I want to talk about is the pancreatic solid tumor. Pancreatic solid tumor, actually in 2002, this is the first EUS-Guided external injection was performed by Professor Genovines. And it is in patients with liver metastasis lesion. And then in 2005 and 2007, animal study was studied to perform to determine the pancreatic tissue ablations with external injection, and they want to investigate the safety issues. Okay. And in these studies, they find that the injections from 40% to 100% external concentration, they can cause very visible necrosis, coagulation necrosis, and fibrosis spread around the surrounding tissues, and not cause a very severe surrounding pancreatitis. So in 2006, I think this is the first report to use external injections in a human. And this case is a case report in insulinoma, and the patients is not suitable for operation. And after use the external injection, the hypoglycemia, the symptom is dramatic improved. Since then, many papers start to publish around about the EUS external injection. Unfortunately, most of this case is just like a small case series. But if you look at I summarize the report, you can see that almost is a small size and not suitable for surgery, and the most is a functional neuroendocrine tumor. And the most important issue is the safety issues, and you can see that the complication is not so high, and mostly is abdominal pain and pancreatitis. Unfortunately, no any patient mortality caused by external injection reported. I want to talk about a technical tip of external injection. In our center, we will routinely give the prophylactic antibiotics before procedures, and we prefer to use a small gauge needle. And later I will say the reason. And now you just like the animal model study, we prefer use 99% external, and before injection, we will prime the external in the FNA needle to clean the air. And while you perform the procedure, we will suggest to inject the injection external from distal part to proximal part. And because the tumor is three-dimensional, so you can use the FNA technique, try to ablate the three-dimensional tumor, and try your best to ablate all of the tumor. Okay. This I would like to show a video. Oh, sorry. Right. Sorry. I cannot play my video. Maybe the internet, the problem of the internet. Sorry, Professor Jun, can you see my video playing?
No, I can't.
Sorry? Okay.
No, cannot.
Why? Okay, sorry. Sorry. Unfortunately, I cannot play this video. In this video, I just want to show that the injection we will inject from the. Okay, sorry. Okay. Okay. Sorry. Can I resign again? Sorry.
Yes.
Okay. Sorry. I repeat. Just. Check. Okay. Sorry. Very sorry. My computer has some problems. So very sorry. Okay. Very sorry. I still cannot play in the. Maybe because due to the internet problems. Very sorry. I will. Because I cannot play my. Okay. I cannot work. Can I, very sorry, Professor Jim, can I disconnect the internet? I rejoin again, okay?
Okay.
Can you just wait me just about 1 minute? Very sorry. Okay. Sorry, Professor Jun, sorry, did you see my slide?
Okay,
Yeah.
now we can see the document.
I'm very sorry because I don't know what's problems of my internet. So I quickly to repeat my slides. I want to show that this slide just want to show while we press the inject the external injection, we will put our needle into the distal part, and from the distal part to inject some external, and then in the EUS needle, EUS view, you can see that some cloudly, hyperlink called cloudly exchange, and then slightly withdraw to the proximal part. Because it's a 3-dimensional, so you need to try to change your needle position, and we call that this FNA technique, just like the Professor Antonio mentioned that is used for FNA. And another issue is that we should select the needle, because the needle is a very important issue, because you need to avoid the needle with traps or side hold. So because they will leak to not focus on the tumor, so we will avoid use the Cook protocol or easy shot 3 with side hold. And another issue is the needle design, because the needle have a different kind of bevel length and the bevel angle. And another issue is the visibility of the needle tips. Why I will talk about this, because this is a bevel length, this is a needle length, and the different kinds of needle have a different angle. And I would summary, this is a different kind of company, and they have a different kind of bevel length and the bevel angle. And now usually we will use in external injections, we will prefer use the easy shot 2 because they have not so long the bevel length, but it's a very sharp bevel angle, and can focus on inside the tumor. And another part is the design of needle tip, is because as you like in this image, in the EUS image, you can only see that have a special cut, and this cutting can just make you can visible this part in the EUS needle, but actually the real needle is here. Sometimes in your EUS window you cannot see, you can only see this part. So this is maybe have a discrepancy between you will perform the EUS external injection will cause some complication happened. And just like this picture, you can also see that. Okay, this is actually the needles here, and in the video, in the EUS window, you can only see here. So this is different kind. The company design have different kinds. So in the medical here have a more short. So I think it's more correlated to a real nipple position. Okay, I show you this video. You can see where we perform the FNA is here, and okay, I repeat. You can see, actually we consume the needles here. Actually, needle maybe is more deeper part. So while you perform the external injection, it was quite dangerous. Okay, in our center's experience, I think it's external injections we most use in the non-operative, not suitable for surgical patient of neuroendocrine tumor. According to our result, I think it's quite safe, and no any patients call mortalities. Okay, I would like to share some video in this case. Before we perform the external injections, we will inject use a contrast. We use a sinusoid, and you can see that is typical for sinusoid. And then we perform the external injection, and you can see the needle maybe is here, and we will inject the external from distal part. And while you inject, we will inject slightly 0.1 milliliters. And while inject, you can see some cloudy change. Okay, so while we inject, okay, you can see that is, and then slightly where you see the inject, and then you slightly withdraw your needle, and then repeat the same injection until the hypoechoic part cannot visible in the EUS. And then after the procedures, usually in our center, we will repeat again the contrast to see any residual tumor inside. Okay. And another issue is this very small neuroendocrine tumor just below the main pancreatic duct, and it's very dangerous to perform external injection because no any approach method. So in this kind situations, we will place the ERPD to prevent pancreatitis. Okay, now I will move to another second portion. Is the second part is about the external injection in the pancreatic cystic tumor. Actually, external injections in cystic tumor is quite controversial. Now published data to perform the pancreatic cystic tumor for external injection. Most is enroll this kind of patient is huge onychonuclear or oligonuclear cyst without obvious communication between the cyst and the main pancreatic duct. And the cyst is increased in follow-up, and the patient is not suitable for surgery. And how about the technique tips of the external injection? Usually we will evacuate the CT fluid before the external lavage, and after aspirate the CT fluid, you need to send, if possible, you need to send the CT fluid analysis. And then the step 2 is after the try to evacuations of the CT fluid content, and then you need to inject the external. And the most important thing is the amount of the injections, external injection amount cannot exceed the CT fluid you aspirate before. And then you can keep the external within the CT with cyst around 3 to 5 minutes, and then you can aspirate as much as possible after external lavage. And some paper mentioned that if you additional after acinar lavage, you can give some chemotherapy agents like paclitaxel or gemcitabine within a cyst. And then the same after injection, you cannot exceed the amount of fluid you aspirate before. This systemic review is very interesting. It summarized all the current literature around about the acinar injection in CT lesion, and you can see that the pure acinar lavage, the complete cyst resolution rate is not so high, it's only around 30%, and the adverse event is around 20%. Mostly is a mild adverse event, just like abdominal pain. And if you look at the literatures mentioned about use acinar plus paclitaxel or other chemotherapy agent, the cyst resolution rate can double higher, around 60%, and the adverse event is a little lower, it's around 50%. This is Professor Shaw's long-term outcomes in acinar injections in the pancreatic CT lesion, and you can see that in the result, the complete resolution rate is quite high, it's around 17.2, and you can see that during the follow-up 60 years, the only 2% patient to have a cyst recurrence. I think that this result is quite good. And another interesting study is mentioned about acinar is necessary or not. They had to comparing the acinar with no acinar, just with chemotherapy, paclitaxel, gemcitabine alone. You can see that the result, they have a better cyst abrasion rate and a low adverse event. So I think that maybe because it is only small sample size, so maybe in the future we need to large randomized control trial to prove the for cyst lavage necessary to need acinar, or just only paclitaxel is okay. How about the complication of the acinar injection? I think the most I just mentioned is abdominal pain is the most common, and pancreatitis just around 2 to 10%, but the most is mild grade acute pancreatitis, and some report portal vein thrombosis or splenic vein thrombosis. The last part I would like to talk about the EUS-Guided IFA. Actually, this is first animal model, animal study in the pig, and they find that after the IFA, around 2 weeks, they will cause coagulation with a fibroid spread, and not cause very severe pancreatitis. And then have some device to design for a pancreas IFA. Now in our countries, we can use star medicine from Korean, and maybe in the future we also can use Harvey systems. And you can see that in the animal model, and after the IFA, they can cause very capsule with a fibrosis band, and the tumor can cause this necrosis. This is recently meta-analysis to enroll 13 papers, and you can see that the very higher technique success rate is around 100%, and the clinical success rate is also quite high, it's around 19%. The most important part is adverse event. It's around 50%, and the most is abdominal pain. It's around 10%, and no any patients mortalities caused by these procedures. Okay, it's the same. Just a summary. Okay, so this is this is Italian study. It's a very very nice design study. This is a prospective multi-center study, and you can see that after 1 year follow-up, they have achieved a very high the tumor abrasion rate. It's around 86%. And I would like to share one case. We perform IFAs in our centers. This is a 37 male. This pancreatic tail metastatic sarcoma. Because this patient meta to many places, just like a heart or in the CNAs, and the patient refused surgery, so refer to our department for IFA evaluations. Just like this video, the procedures is very like the external injection, and just like FNA, and you punctures use this is a 19 gauge needle, and the tip is here, and you can see that abrasion area is here, and while you perform the radiations, we will setting is 50 watts. And around 10 seconds. During abrasion, you can see some hyperechoic bubbly appearance. And then you can slightly withdraw your tip and slightly overlap your tumor size and repeat this kind of step. And try to abrasion whole tumor spot. In this patient, because the tumor size is pretty large, it's around 5 centimeters. So we total perform the 36 sessions during these procedures. And do this leg again. Try to abrade all the visible parts. The most important part is you need to very caution about the tip or abrasion part not too close to the duodenal wall or gastric wall. If too close, you may cause the fistula or some problems in the futures. So sometimes we will see the appearance bubbles very close, and we will stop the abrasion. And after the abrasions, or just like external injection, we will use contrast EUS to evaluate the efficacies of IFA. And you can see a lot of perfusion after the IFA. And 1 month later, we follow contrast CT again, and you can see most part is abrasions. And 5 months is a slightly recurrent residual tumor, but I think it's slightly good, the size not enlarged. So I would like to summarize my today's talk. I think the EUS-guided abrasion therapy is I think it's the best combinations of a real-time visualization and can perform precise localization and with safety. However, most publication of EUS-guided tumor therapy are experienced on small study population. And I think in the future, we need a large prospective randomized control trial to confirm its role in cancer treatment. Thank you very much.
So thank you very much, Dr. Pure. Very nice presentation. And is there any question? So we have no experience in this field. So, but with very promising result, I think this technique will be have the future. And in your experience, is there any severe adverse caused by
actually
adrenal injection or RFA?
Oh, okay. Thank you, Professor Jun, your questions. Actually, up to now, while we perform this procedure, is quite very safe. Mostly, just I mentioned in my slide, mostly it's abdominal pain during the first day. And very rare have pancreatitis, but mostly it's just keep NPO and pain control. Mostly 2 or 3 days later, they mostly these kinds of people can discharge, and it's okay.
What is the criteria for choosing the treatment mode, like internal injection or RFA? Do you have any criteria for choosing?
I think it's a very good questions. Actually, now still no very strong evidence to mention which kind of population is more suitable for this kind of anti-tumor therapies. So in our center, we mostly perform external injection or IFA, just like especially in the first population is a neuroendocrine tumor. And some neuroendocrine tumor is very small size, it's just below 2 centimeters. And some patients refuse operation, and some patients is not suitable for the surgery, and we will perform the external injection to this kind of patient. Another population is multiple AN1 patient. They have a multiple neuroendocrine tumor from head to tail, and usually if the patient have a functional and not suitable for, because it's multiple neuroendocrine tumor in AN1, this kind of population, we will choose the biggest one or large one to perform the external injections or IFA. And then now recently we have some experience to perform to the pancreatic cancer, not suitable for the surgery, and maybe the pancreatic cancer cause the biliary tract obstruction or some severe pain, and we will use IFA to perform palliations therapies. As you see my last case sharing with all of you, IFA case in the pancreatic sarcoma, this kind of patient, you can see that it's very difficult to comprehensive totally ablation in the tumor. So I think the role of the IFA, US IFA, maybe I think is more just like a palliations. Yes, it's my personal opinion.
Yes, because of the RFA procedure, we need the device. But external injection is easy to use.
Yes, yes. Yes, and more cheaper, and it's very easy.
So is there any comparison?
We are
study comparison between the efficacy of external injection
yes,
and RFA?
Thank you, Professor Jim. You're very nice suggestion. Actually, we now start ongoing some comparison study to compare external injections and IFA. So maybe in the future we can share some of our preliminary data with of you. Yes.
So this pulmonary tumor, have you experienced with the IFA or external?
Okay, there is one question.
Yes.
In case the patient had the SPN.
Spain. Okay.
Do you use external injection or RFA in this case?
Actually, we will suggest patient to receive the surgery. If I think the surgery is, in my opinion, is the first choice. So if the patient can receive, the first choice is a surgery. If the surgery is not feasible, I think the size is another issue. If the size is bigger, I think IFA is more easier than external injection. Yes, this is my personal opinion.
any question? So anyway, thank you very much for very nice lecture.
Thank you very much.
So our lecture are finished, right? And now it's time for post-test.
Okay, I will launch the post test now.
Yes. Jason, please.
So again, same as the pre-test, 5 questions, same as the pre-test. So you'll be given 5 minutes. So for those who are attending online in Zoom, you will see a screen popping up now. Okay. So the protest starts. So for those who are attending in the hospital, so you will see the questions. So question 1 now. Now question 2. So now question 3. Question 4. Last question, question 5. So all question 5 is answered. 5 minutes has passed. So it's the end of the post-test. So I'm now going to share another slide.
Okay, thank you.
So may I invite Prof. Ang to explain the answer for question 1?
Hi. So I think as I mentioned in the lecture, I think if we were to puncture a necrotic tumor region, we may not see any viable tumor cells, and that's why we should avoid. I think things like FNB needle, fanning, and suction have all been shown to help improve the diagnostic view. Yeah. Okay. So okay, question 2 about so I think in a person who has multiple liver metastasis where the lifespan is very limited, I think we should avoid surgical bypass. And we know that we should try not to use a plastic stent nowadays, and therefore B is also wrong. Because the person has multiple liver metastasis, it may not be so good to do a HGS, and therefore the correct answer is to do a EUS-CDS. Third one, okay, I think, okay, so I think which is the correct answer. So I think okay, so firstly, the axis of the puncture tract must be straight so that we avoid problem of malalignment. Secondly, as I shared during the lecture, we should just dilate enough for us to insert in the delivery catheter. So I think 6 French should be enough. If you want to, you can go up to 7 French. But there is no need to dilate. To dilate to the internal diameter of the SEMS means we dilate to 10 mm. And that will actually create a very big fistula tract and will cause leakage and stent migration. And therefore, that is also wrong. And in a case when the bile duct is only 1 centimeter dilated, the standard SEMS is actually preferred because it is safer to insert. A LAMS there may be no space for us to puncture it in to insert because the axis is actually perpendicular. And after insertion, it may actually collapse. The wall of the bile duct may collapse on the inner flange of the stent and therefore affect drainage. So the correct answer is C.
Thank you, Prof. Ang. So for question 4 and question 5, may I invite Dr. Ko to explain the answer?
Okay, so I just mentioned in my lectures, I have talked about the technique tips of a EUS-Guided adrenal injection for the solid tumor. So as you see, the first part, according to the animal model, I think usually now we will use a higher concentration, and they can cause is more coagulation necrosis. And usually we will apply the ethanol in FNA needle before clean the air, so it's correct. And we will use to inject from distal to proximal parts, and we will use the fanning technique to try to ablate the three-dimensional tumors. Okay, so now we prefer use 25. Oh, sorry, this is a wrong word. 25 gauge, because it can more precise to give the amount of ethanol. So I think this is answer is the wrong is E. Okay. Okay. I think most doctor is already choose the right answer, because if you want to predict the amount of your want to inject ethanol amount, you cannot exceed the city fluid you aspirated before. I think it's a very important point. So this is these questions. Okay.
Thank you, Dr. Go. So that's the end of the post-test. So that's and a last reminder that please complete the online survey after this workshop. So it will appear automatically at the end of the workshop, or you can scan the QR code right now to get access to the survey. So thank you very much.
So thank you, Jason. And now it's about 10 to 11. So we finished a little bit early. So I would like to close this morning session here. And on behalf of the FDA, I would like to express my thanks to AEG, Dr. An, Dr. Kyo, and all doctors for taking your time to join this webinar. In my opinion, we had a very effective morning to learn more about our interventional EUS. And I do hope that more and more Vietnamese endoscopists can apply these interventional EUS procedures in very near future. I also thank to Olympus for support this event. And in the afternoon, we will continue to have live cases. And thank you very much, and see you soon next workshop. Thank you. Thank you very much.
Thank you very much.
Bye bye.
Thank you very much.
Thank you.
Bye bye.
Bye-bye.
Bye bye.